My name is Dr. Rami Khouzam. I'm a professor at the University of Tennessee Health Science Center in Memphis, Tennessee. And I just talked today about the peripheral interventions and antiplatelet therapy and the role in the current practice and guidelines in 2018. So basically, peripheral arterial disease, as you know, is, as I like to call it, is becoming the mass epidemic, 3 to 12% and up to 29% incidence. Now, revascularization strategies, we are having great improvement in the endovascular compared to the surgery. And the endovascular actually has increased at least threefold, while the surgery has decreased by 42%. What I talked about also was the antiplatelet therapy. As we know, platelets have a fundamental role in the development of atherothrombosis, which is very important in peripheral vascular disease. Now, antiplatelets do play a role in pre and post interventions. However, the guidelines are not very clear, and that's why I wanted to follow on where we are in 2018. For instance, the first and one of the oldest medicines, aspirin, derived from the willow tree, as you may know, has a class 1 recommendation per the ACC/AHA guidelines for peripheral vascular disease, 75 to 325 milligrams a day. But guess what? This is only derived from the coronary data. Now, Plavix or clopidogrel is also considered and has been compared in the Capri trial, again in a coronary disease study, but they always do subgroup analysis. And solo use of Plavix, 3.71% versus 4.8% average event rate compared to aspirin, which is like a 24% relative risk reduction. Dipyridamole and aspirin combination has been studied in studies like the ESPRIT trial. However, there is no clear guidelines on that. Ticagrelor, which is a P2Y12 inhibitor, like as some would like to call it, the expensive brother of Plavix. It's not just the expensive brother. It was shown in the Plato trial for coronary artery disease, ACS, to be of tremendous benefit. However, in the PVD or peripheral arterial disease, it wasn't proven. They did a head-to-head comparison in the Euclid trial, comparing ticagrelor and Plavix, and there was no clear benefit. Cilostazol or Plital is a great medicine for symptoms mostly. It's a phosphodiesterase 3 inhibitor, and it's mostly for symptoms and approved for that. Vorapaxar, or the protease activator regulator inhibitor, there are studies. There is a big study, actually, the TRAP TIMI-50 trial. However, no obvious guideline on that. Now, dual versus mono antiplatelet therapy, there are a couple of studies, again, extrapolated. The MIRROR study is one of the very few studies that showed the duration, because duration is one of the main things that we keep looking for, and we don't have the answer. So 6-month duration post-intervention. Now, how about anticoagulant therapy or vitamin K antagonists and Coumadin and the such? There is one big trial, the BOA, and in a nutshell, basically it was noted that anticoagulants have no clear benefit except for if the patient had a venous graft. For prosthetic grafts, it's actually, it can be counterintuitive. So bottom line, for oral anticoagulants, in one word, it's still a class 3. Now, the novel agents, the DOACs, there are studies ongoing. And again, the post-treatment therapy after an intervention, duration therapy is still a big question mark, Now, what do we have in the guidelines? The clear, as of 2016 guidelines, class 1A is aspirin, 81 to 325, or clopidogrel. A class 2A, antiplatelet therapy is reasonable for asymptomatic patients or post-intervention. Class 2B, the dual antiplatelet therapy, aspirin and clopidogrel, and a class 3, coumadin or the anticoagulants, no clear benefit. So in conclusion, there are so many advances in the peripheral arterial disease treatment, and endovascular treatment has been really taking the upper hand, less invasive and very effective. Now, as far as treatment with medications, the antiplatelet therapy is a mainstay, and it's very beneficial. However, because peripheral vascular disease is a little like the underdog, we only have data from extrapolated studies from coronary disease, so we don't have enough data to prove duration of treatment and what exactly is best. So we need more studies and trials.